Hello and welcome to 24/7's webinar, a practical and proven approach to 100% PM completion. I'm Sri Roy, Editorial Director of MedCore, filling in for 24/7's editor while she is on maternity leave. Today's webinar is sponsored by PartSource. I am here with esteemed speaker Steve Kelley, Manager of Diagnostic Imaging Repair at Piedmont Healthcare. Steve will use your feedback to direct the scope of today's webinar. So to tell Steve what you'd like more information about, please take the audience poll that is now on your screen. The question is, what is your biggest concern with not getting 100% PM completion each month? Please select from the choices on your screen. Then click the Submit button so we include your response in the calculations. If your choice does not appear, you may type it into the Q&A box on the left side of your screen. You may also type your questions for Steve in this box throughout today's presentation. Without further ado, I give a warm welcome to Steve Kelley.
Hello, everyone. Thanks for joining us this morning, or this afternoon, I should say, according to where you're at. To all the ladies and gentlemen that are here, I want to give a brief introduction while you're filling out this question, how this program or this presentation came to be. But first, I need to tell you where I'm having this calling from and presenting from. I'm actually on vacation this week. I'm camping out at Grayson Highlands State Park in Virginia, and they have no internet and no cell phone connectivity whatsoever there. So I had to drive about 45 minutes away to a small town and found the City Hall of Lansing, North Carolina, who has a meeting room and Wi-Fi and invited me to come in and do my presentation here. So a big shout out to Lansing, North Carolina. But the way this came about, 2 years ago, I was at an AEM conference meeting. And that's when, if you remember, the Joint Commission changed their rules from 100% PM completion for life support and 95% for non-life support. And they did away with that and said you had to have 100% for everything. And I heard a lot of grumbling and complaining. Well, in step back, 2008, I was at an AEM convention, and George Mills was there talking with the Joint Commission. And he gave out some pointers that I'm going to be sharing with you today that I took back. I grabbed and took hold of those pointers that he gave out and went and developed this program back in 2008. So that's where this came from. But when I heard all this complaining and grumbling, I said, hey, I've got a program that works. And I actually approached the MD Expo group and gave this presentation in April to a standing room only meeting in Nashville, and PartSource came to me and said, hey, could I present this one here with 24/7? So I want to thank 24/7 and PartSource for supporting this and going from there. So I'm going to move, well, first before I move to the next slide, let me explain practical and proven. Practical, this program does not require you to purchase anything. You do not need a tracking system. You do not need a special CMMS. Full disclosure, I do have a tracking system in 7 of my 11 hospitals with plans to put it in the others, and it does help to find equipment, but it's not needed for this program in any way. CMMS, I do use AIMS by Phoenix Data as my CMMS, but there's nothing specific particular to that for this program that will work with any of yours. Proven. What does proven mean? Well, I've gone through 25 or 30 inspections between Joint Commission and DNV and CMS, state inspections. But I don't consider that proven. Several years ago, about 3 years ago, I guess it was, I presented detailed information on my program, my policies and procedures, to senior Joint Commission inspectors when they were there and to senior DNV inspectors when they were there, and asked them to give me some feedback. And all of them had great things to say about the program and said it was perfect the way I'm doing things. So that is my proven point there. The key thing in this presentation is laid out a little bit differently. My goal is to change your perception, your paradigm, if you will, of what PM completion is. So that's the reason it's going to go the way it's going to go. I want to totally change your thought process. So I'm going to move to the next slide here, and let's see what our concerns are here. Can't find the device, 54%, devices in use, 18%, not enough staff, 22%. And you've got some other concerns here. Well, let me make your day by telling you I'm not going to help you to find the device. I'm not going to help you get the device out of being in use, and I'm certainly not going to help you with not enough staff. But I am going to give you some tools. I'm going to give you some rules. I'm going to tell you how I'm using them. Hopefully you're going to have the rules and tools here to take it and add it to your program in the way that will work with your program. Every program is different. So this is not telling you how to do it. This is giving you some tools and a way to do it. All right? So let's go to the next slide and get started. The number one goal of a healthcare technology management program is safety. That's our whole reason for being there. So the question is, who is responsible for safety in your facility? Now, if I could hear all of you, you would all be shouting, everyone is, right? Everybody's responsible for safety. So how do you enlist the help of clinical users to make sure the equipment is safe to use? Or do you even think about enlisting their help? All right. The Joint Commission has said that a device is no longer safe to use after its PM due date set by your program. So you have some options. You can use manufacturer's requirements or AEM Program. You know those rules, and you can set up how often the PMs are due. But Joint Commission said once you set that and you said this is the time period for the PM, once it goes past that due date, that piece of equipment is no longer considered safe. So just keep that in mind. Our program's about safety. It's no longer safe if that's in use. So how do you know when a device is safe to use? This is a question we use at our hospital all the time. We go around and ask the clinicians on our safety rounds, how do you know this device is safe to use? Any medical device, how do you know that it's safe to use? Well, what we've enlisted to help us, to help our nurses, is stickers. Now, there's no requirement that you have to use stickers, okay? So I'm not telling you have to use a sticker. I'm just telling you how we do it. Our goal is we have this green sticker, and it has the date on it that it's due. Everyone knows that they look for this green sticker. Green because it's unique. It's different. You don't see many other green stickers from other vendors on there. So the green sticker says, oh, it's part of our biomed program. We're managing it. So if they happen to get one that a vendor brought in or somebody brought in to use, it doesn't have the green sticker on it, instantly they don't see the green sticker. They contact biomed. Hey, this one doesn't have a sticker on it. Are you aware of it? So that helps us, number one. And number two, it's got the date right there in front of them. We make sure it's right in front of them wherever we mount it on the piece of equipment so that they're seeing it in their eyes. They don't have to look for it, okay? And they're taught that if it's past due, it's no longer safe to use. Now, do we get 100% of all of these brought to us? No, we don't. But we do get a high volume of them brought to us. They do know how to answer the question. And when we do find one in use that's past due, we do what we call RL at our facility. That's just our incident reporting system. We write up an incident report that goes back up to administration that nurses on this floor were using a piece of equipment that was not safe to use. So that's how we manage that. That's how we utilize that to make sure we're safe. This is a very important piece of this program. Okay? You're going to see why on the next slide. Pause in a minute to let you read this slide. TJC, the Joint Commission, or DNV, does not care when the PM is actually completed. You're saying, whoa, wait a minute. This is about 100% PM completion. All right, this is the paradigm change. This is where you got to think about this and be aware of it. Okay? Here comes rule number 1. The Joint Commission is concerned if a device is used on a patient after its PM due date. That's their concern. They're wanting to make sure that it's safe, that we're following a safe process. So their big concern is a device used on a patient after its PM due date? Now, obviously, if we're 100% PM completion, we did every one of the things out there, we found every piece of equipment, then we wouldn't have any devices used after the PM due date. But obviously, we all know that that's not realistic. So how do we manage that? Okay, remember this rule number 1. Safety is our big deal. We just talked about that. They're concerned that a device is no longer safe to use after its PM due date. So how do we manage that? Here's rule number 2. George Mills of the Joint Commission has said in several meetings, if you cannot locate a device, you should not hold it against your PM completion. It may not even be in the hospital. Okay, so if you have a process to manage missing equipment, you can count your process as completed. I like to call it 100% managed PM completion. All right, we'll talk about how we do that and document it. In our system, and this is where you can adjust yourself to fit in here, but in our system, on missing equipment, we have to document on a work order 3 attempts to find that throughout the month. So that they've been trying to find that equipment. They also have to send a report of missing equipment to the department manager and copy the biomed manager. So as a biomed manager, I'm managing that they have sent this email out by the 25th of the month saying, we can't find this piece of equipment that belongs to your department. Help us locate it. A follow-up phone call must be made by the department manager, or made to the department manager by the tech. All right. And then at the very end, the equipment status must be changed to missing. That's what we do. You can find your way of doing this, but we change our status from in use or in service to missing in the work order database. That allows us to document that this was missing. All right? Once this process has been followed, the work order can be closed with a comment of PM could not locate. Now then, our system will count that PM because it's closed as completed. So now I can have potentially 100% PM completion, but then I have a report I run that says PMs that were closed with an exception, missing equipment being an exception. So now I can go to my safety committee and say, I was 100% PM completion managed, and I had X number of devices that were missing and not located. So that they have full disclosure, they're aware of what's missing, what's not located. They can see that number and watch that number grow and fall, come back and forth. And as we go back, that we've got nurses working with us and finding the equipment and bringing it to us, and they're all aware of that when they go around and ask the question. They're showing this process is working. So far, the Joint Commission does not care when a PM is completed. Their main concern is that no unsafe equipment is used on a patient. Make sure you involve the clinical staff, be part of your safety program, and you have to have a process to manage the missing equipment. Rule number 3. In use, not available equipment. George Mills has also said that if a critical device is connected to a patient, then you know it's working properly. Your goal is patient safety. And if it would create an unsafe condition to swap out that equipment, you should not count that against your PM completion. Well, you got to have a way to manage that. You can't just throw this out there and say, oh, all my stuff is in use. You got to have a process to manage that. But the Joint Commission said, hey, we understand, and if you've got a process and you've followed it, you're allowed to do this. So what do? When we find a device that's due for PM and it's in use, we attach a card to that device stating that it's needed for PM when it comes available. The work order status is changed to in use and notified. And we document at least 3 occasions of attempting to get the device. So similar to the missing equipment, we're going back to that department, we're talking to the users, we're documenting in a work order at least 3 times. And if ever we find a piece of equipment that was on a particular patient in a particular room, and now then this is on a different patient in a different room after we've started this process, again, that's an incident report that goes out to administration to say, hey, the nurses are not following the process here. Administration should be able to back you with this 100%. Okay, same thing. A report is sent to the department manager letting him know, and it's copied to the biomed manager so that they have a paper trail to document this. All right, and then it'll be closed out at the end of the month as PM in use, not completed. Now, in our database, we've got it programmed that whenever this is closed out, it automatically creates a corrective maintenance work order to track this device to completion. Okay, so that we know to stay on top of it and be aware of what's going on. Now, we have another example of this PM with issue. You have PMs that are due for repair, and you send it out to be repaired. It's not going to get back in time for the month. Or you've got parts on order for this repair, and it's due for a PM. You can't do the PM until you get the parts in, and they don't come in until after the end of the month. You do not have to count that against you, because Joint Commission goes back to the rule of they don't want the equipment used on a patient after its PM due date. So what they allow you to do, if you've taken this piece of equipment out of service and you know it will not go back into service until the preventive maintenance procedure has been completed, you can count the day you took it out of service. All right? Take the day you took it out of service as the PM completion date. So let's go back over this. And I'm hoping some of you are raising some questions here and writing those in. So we're going to have plenty of time for lots of questions here. So review the safety is the main piece of our program. Joint Commission says the device is no longer safe after its PM due date. Joint Commission doesn't really care when the PM is completed, just like we said. As long as you take it out of service and the PM is not really completed till next month, it doesn't matter. It was taken out of service. It's not being used on the patient. You're good to go. Rule number 1, Joint Commission is concerned if it's using the patient after its due date. Rule number 2, you shouldn't count it against you if you can't find a piece of equipment. Just have a process to manage it. Rule number 3, if it's in use, you shouldn't count it against you. Have a process to manage it. All right? Now then, you have to have a process to identify and manage all these exceptions, missing in use, items sent out. One of the things that Joint Commission and DNV has recommended to us is to make sure there's a combined running record that we give to our safety committee. For example, let's say out of 10,000 pieces of equipment, I've got 50 devices that are missing, all total, currently in a missing status right now. Well, that number should fluctuate. As people are finding those devices, it should go down. PMs come through again, and you have some more that adds to it, it'll go up. It'll move back and forth. You've got to have a process to take them out of the missing status. What we do is we say if they're missing 2 PM cycles consecutively, then we retire those. So those come off the list. So you constantly see an ebb and flow and have a base number of missing devices, and everybody in the safety committee is aware of what those are. All right, this is back to what I was just talking about. You've got to have a way to show that you're 100% managed on your PMs, that you're 100% PM completion, and then here are your exceptions, and here's how you're managing your exceptions. One of the concerns, and I'm sure we'll get into this more here in the questions and answers, be quick to not allow your staff to be 100% PM completion if you've not followed the process. All right. Hang on one second here. All right, you've got to closely monitor the program. Show how you justify it. Use the email trails. Keep tabs on how many devices are closed with exceptions per technician. You want to manage it by technician. And what equipment types that you're having issues with. Look for trends. Look for abuse of the systems. Make sure your clinical staff is involved. Now, you're not supposed to read this, so don't try to read it. I've asked if they have some of my terms and conditions, not terms and conditions, sorry, my standard operating procedures that detail this out of how we do it are available for you for download. You should see that on the screen, and we'll go from there. All right, we'll open this up to talk about the questions.
Excellent presentation, Steve. Great starting point. And yes, let us move on to the questions. We've got a lot. So the first one is, what about techs abusing the system and closing out missing equipment work orders just to complete the month?
Perfect. Absolutely. This is a concern when you have a program like this. It does give some leeway for it to be abused. So you have to manage that. Just like you manage, you don't want to have people, what we call pencil whipping their PMs, just closing them out to get them closed. So if you got a process to manage that, then this opens another door. What we have done is we've created a scorecard for each of our individuals. And in the scorecard, you have your PM completion, we have turnaround time on repairs, we have average age of open work orders, things like this that are important to us. And on that is missing equipment, could not locate equipment, in-use equipment. Both of those are on that. We color code them. We've got blue, green, yellow, and red, and we've got numbers on them. So blue is you have 0 missing equipment. Green, you have up to, let's say, 1% missing equipment. Yellow, you've got over 1 but less than 2. And red, you've got over 2%, or you can adjust those percentages how you want to fit in there. That way, anybody that's at the yellow or red level each month, I'm going back and digging into why did they have this much equipment based off percentage missing? Why did they have this much in use? And look at it to see if it's valid, see if it's real. Maybe if it's a month where they're doing infusion pumps and you got 400 infusion pumps, they may have a higher percentage that month. That may be realistic. If this is their month to do something like CTs that are fixed, they couldn't be missing. So you know that's an issue. Patient monitors that are in the ICU that are fixed, they should not be having any issues with those missing. So you use this to help stay on top of your techs to make sure you're monitoring it, make sure it's not being abused. Your inspectors, Joint Commission, DNV, when they come in, they will be asking those questions and going through that. What's another question?
Excellent. Yes, here is the next question. If you have a vendor-supported PM shipped out that is due by June 30th, as an example, and it is July 1st, how do you report this device? Is this PM considered complete?
Yes, again, if you take it out of service and you know it's not going back into service until the PM is completed, you can count it PM completed. What we do is we put PM with issue or PM with repair, however you want to label it in your device. So it says PM was completed with an issue. That creates another corrective maintenance work order to manage the issue side of it. But my PM is completed as of the day I took it out. So I can say PM with issue sent out for calibration, and it was sent out on the 15th of the month. It didn't come back in until the 10th of the next month, and my corrective maintenance work order will follow up. It came back in, you did electrical safety on it, verified the operation had just been PM'd, and you put it back into service. So now then you can follow that in your history of your piece of equipment, and everybody can see that it was not used after the date you took it out of service, and you counted your PM completed at that time. And that is perfectly fine with Joint Commission DNV.
What is your definition or time frame for PM cycles before you retire a piece of equipment?
Perfect. I think I mentioned that, but it's for us, we do 2 PM cycles. So if it's a yearly PM on the second PM cycle, we're doing it. If it's a 3-month PM even on the second PM cycle, we take it out of service with the understanding that if they happen to find it, they should be finding it if it was in a closet, let's say, the first time they pull it out of the closet and it's got a past due sticker on it, if they're using stickers, they should be notifying us immediately, and we feel comfortable that it was not in use, and we can put it back into service and show the history of what happened on that.
Great. Next question. Is there a standard or percentage used as a goal for missing, lost, or in use?
Yeah, I've used anything over 3% is a huge number. That's the way I typically have used it. You'll have to vet that out for yourselves, but for me, anything over 3% is a major issue I'm dealing with. I like to see it below 1%, but again, it varies on what's due that month and what the situation is. Again, infusion pumps are going to have a higher missing issue than, say, patient monitors that are mounted on the wall.
Pulling up the next question. You stated that you should look for the item 3 times. How long do you recommend between these attempts?
Well, that's a good question. We definitely make sure it has to be at least a day difference. So you can't put it in 10 minutes apart or 3 times in one day. We don't have a hard, fast rule set for us for a length of time other than that one thing. It needs to be at least a different day. One of the big concerns is, the equipment types that are going to be issues of trying to locate. Don't try to locate those on the last 3 days of the month. Even stuff that's in use, high in use items. Don't wait for the last of the month. You need to be focusing on there to give yourself time and look for those trends, look for things that are standing out to say, hey, you got to do this a little differently in order to capture these. The goal, this is not a goal to get 100% PM completion. This is a goal to help you manage your program appropriately. That's what the goal is. The goal is safety, okay, and making sure your patients are safe. And if you look at it from that perspective, this is not a way to cheat the system. This is just a way to manage things, because there are things that are going to walk out of the hospital. An infusion pump goes out with an ambulance and goes to a different hospital, so it's truly not in your hospital for a while. Things like that.
On that note, how do you address missing equipment that does not belong to a specific department, such as infusion pumps that are centrally distributed? Which department would you notify when these devices cannot be located?
Very good question. That's a very good question. In our facility, we have an equipment distribution group. All infusion pumps go through that equipment distribution group. They pick them up out of the soil utility rooms, they clean them, they take them back and distribute them to clean equipment rooms, and they're handling all of the pumps. Nobody keeps pumps in their area specifically. So they're the ones that we address this to. We also take it to our safety huddles. I think most of you now are doing safety huddles when we're having issues during the month for infusion pumps, for example, or even beds, and we're getting close that we're in that last week of the month. We're bringing it to their attention, saying, hey, these items are missing. We're having trouble with it. But again, I go to our equipment distribution people, and I'm lucky we do have a tracking system. If you're lucky enough to have a tracking system, that helps you to locate. These are on 4 South, so now you can go to 4 South and say, in room 418, I've got a device there that I need to get a hold of.
Next question is, do you generally assign PMs to individual techs or to a team of techs and let them decide who does what? Okay, I've seen this happen both ways. Me, personally, our facility, we design our program around a tech is responsible for either equipment type or for a department. So this particular tech has ICU, for example, and everything that's in the ICU. Or this particular tech is infusion pumps, and he does all the infusion pumps for the system. So that's the way we do it, but again, this program is not specific to that, other than if you're doing a general thing that says, okay, everybody's going to do infusion pumps, everybody's just got to come and grab some and do them, and you don't have a single person responsible for them. That makes it harder to manage and capture who is
faking the system. It does. You'll have to figure out how you can manage that yourself if you don't have a responsible person for that.
Do you think that making a daily work order for PM rounding by department would be sufficient to show that attempts were made to locate it versus having to make time allotments in each work order?
That's going to be your call. Like I said, this is totally open. This is rules for you to take and do your own thing. What my concern is, I want to make sure a tech is looking for that particular device when it comes down to the end of the month and they're going to close it out, as opposed to a tech saying, I went in the ICU and I looked for pumps in the ICU. Well, I need to know we're looking for this is a particular one that I can't find. I need to be looking for this particular pump uniquely, or particular device, whatever it is. But again, this is something you would adjust.
All right, next question. Is there a template available of the technician scorecard?
I can put one out there. I'll ask the 24/7 group. I can email a copy of a template that you can share with the people if you would like. I'll be glad to do that. Get with me after this, and I can share it out, and they can share it out to everyone. Is that possible?
Yes, I think so. Send it to us after the event, and then we should be able to get that distributed to everybody who attended today's event, yes.
Perfect. I wasn't the creator of this template. I actually stole it from someone else and customized it for myself, so I'll be more than happy to share that with you.
Great. Does anyone perform PM more frequently than the manufacturer's recommendations?
I would say yes, absolutely. It can even vary by department. A good example, let's say C-arms. A C-arm in OR is used a lot more than a C-arm that's in a pain clinic, let's say. And there's a lot more problems with the one in the OR, not very many problems in the pain clinic. So maybe I'm doing them every once a year in the pain clinic, but I'm doing them every 6 months in the OR just because there's lots of damage, lots of misuse in handling them, and they need more care. So I would say, yes, you do it by your facility or by your departments and find out. The goal is to make sure the equipment's up at its best, and if you're seeing issues, you increase that.
Great. This next person is wondering if they can download your presentation to present to their staff, which is great to share it. I just was going to jump in with two things on this. One, today's presentation is recorded, so you can provide any and all of your staff with the same link that you use to register, and they can watch the recorded version. And then 24/7 has its own YouTube channel, and sometime next week, the video of this presentation will actually be on the YouTube channel as well. And then did you have anything to add, Steve?
I am presenting this one more time in August at the Georgia Biomedical Instrumentation Society meeting in August, GBIS. You can look it up if you live somewhere close by there or you're going to be in the Atlanta area in August. I think it's like the 8th of August, I believe. Don't hold me to that. But I will be presenting this live again at that point.
Fantastic. Do you have equipment that is not due within the 30-day period of a month? An example is non-life support or non-direct patient care equipment. If so, how do you handle the months shown on the sticker and the Joint Commission rule that it's not safe to use after that month?
All right, I think I understand what you're asking here. We have some equipment that we do not do PMs on. I'll say it two different ways. There may be one that's more than 30 days. So let me go two different routes. We have some equipment we do not do PMs on. We've determined this is not part of our PM program. It doesn't need to be. But to follow our safety rule and using our clinicians to make sure our equipment is safe, we put a green sticker on those that say not part of the PM program. So they know it's got a green sticker on it. They know that we're managing it, and it tells them there's not a PM due date that they need to be aware of. That's one thing. The other thing may be our infusion pumps. We have a AEM on it to say we do them with a 60-day grace period. So if they're due June 1st, they're not really due in our system. They generate June 1st, but they're not really due or past due till July 31st. So we put July 31st stickers on all those, even though we may do them June 1, June 2. They're getting a July 31st because that's technically when the PM is required to be done by. So that takes a little thought process. They all generate 1st of June, but they're not due to July 31st. Hopefully that answers that question.
Excellent. Do you track the quality of the PM performed by technicians?
Good question. I would love to talk to you about that. That is, I think, something that is needed more in the biomed programs. Do I have a specific way of tracking quality? No, not at the moment. I do not. It's just more of a general way I think everybody typically does of looking for breakages after the PM is done or repeat calls, things like that, talking to the department, seeing how things are going. I would very much be interested. This would be a good presentation for you to put on, if you've got a handle on this, is how are you managing the quality of that? So good question.
How do you deal with vendor consignment or loaner equipment?
We call it non-hospital owned equipment. We track that. Our particular way of tracking it, we created a NHO dash in the hospital number since we're a part of an 11 hospital group. So I've got this equipment tag, this non-hospital owned tag, and every piece of equipment that comes in gets a work order under that NHO, and it's documented by equipment type, manufacturer, model, serial number in the problem area. So I can scroll down the history and see all the open work orders and see what pieces of equipment are because the problem area shows in my history down that. And then it stays open until it leaves the hospital, and then they close that work order. And now I've got a timestamp of when it was brought in, a timestamp when it left. And if we have any issues or repairs, we just put it on that work order that we had to call them in or whatever for that. We manage our equipment that are non-hospital owned to say this work order cannot be open. No non-hospital owned work order can be open more than 5 months. If it gets into the 6th month, we have to inventory that piece of equipment and actually make it part of our PM program where we're managing the PMs. We check to make sure the PMs are less than 6 months due when we bring it in. If it is less, then we need to highlight that and manage it to that time period. If it's due in 3 months, we need to be managing that to know that 3 months this needs to get out of here or have them come do the PM on it or whatever. That helps us to meet their requirements so we know what non-hospital owned equipment's in the hospital, and we know what the due dates are on them, and we will start managing them if they're here longer than 6 months.
Do you close the PMs at the end of the month?
Yes. Our goal is to have every PM closed. The only time a PM would not be closed is if we just did not have time to go look for it. So if someone said that their issue is manpower, I can't fix that for you, and you need to be able to use this to highlight that. Anything that's left open, you're saying, I didn't have the time to go look for this. I wasn't able to follow my process, and it's due to manpower. And now then you see your PM completion is going down because you can't get to them. That's something to go back to administration. That's something to let Joint Commission DNV know if they're coming in. If administration's not working with you, let them know, hey, we were only 98 or 92%, whatever it is, PM completion, and the reason is we don't have the manpower to get to find them to go and do the work. And that will come back to highlight it to your administration that they need to assist you in doing this.
CMS defines critical equipment to be the devices that, if they fail, could result in injury or death. Yet, depending on which Joint Commission inspector you get, they may claim that imaging devices are critical. What's your take on this?
Well, my understanding is they've done away with the life support type designation. So I don't really look at critical or non-critical. To me, it's all the same. It's all got to follow the same rules. It's all got to be done the same way. So I'm not sure what you're trying to get at when you're talking about critical and what you're trying to use critical to help you with in your process. If you want to expound on that some way, I don't know how to answer that.
How do you manage a large fleet like electric beds for PM completion throughout the year?
Oh, that is easy, isn't it? I pause to hear the laughter. The one lucky thing for us in the hospitals that have the tracking system, we know where all the beds are, and we spread them out evenly across the year. So we've got the same number due each month, and we can go to the rooms and say, hey, this one's due. And so that when they're changing patients out, they can swap beds out, and we can get to them. That's our process. If you don't have a tracking system, and if you're like our hospitals, the beds move like crazy. I don't understand it, but the same bed is not in the same room for more than an hour sometimes. I don't know. It makes it harder. It definitely does. But you need to solicit through your meetings that you have every morning, your safety meetings. Bring it up and talk about it and get solutions from your medical director, from your nursing managers. So how can we best do this? I know our hospital has said, wow, it's easier to swap out these beds and get them to you between 3 o'clock in the afternoon and 9 o'clock at night. That seems to be the time when we're letting patients go home and turning the rooms over, more so than in the early mornings of the day. So that may be something you need to adjust a time schedule and to work with them to find what's the way to do that. But this is something that you have to figure out what works best for your particular facility.
I have an anesthesia machine, high risk, awaiting a service contract to be finalized by the hospital. Most likely this is going to be past the scheduled month. Any recommendations on how to handle this, or is it poor planning by the hospital and the biomeds take a hit?
No, biomed does not take a hit, and you want to make sure your hospital is safe. So if the contract is not going to be in place, and understand it takes a while for them to go through their legal departments and all that, you just call it in and pay time and materials. You get the PM done. Safety is getting the PM done, getting it taken care of. You're not going to let this go past. Now, you can negotiate with your vendor, hey, you know, we're going through this. We're going to get the contract. It may not be till September, but I need PMs done in July. Can we work something out here? But bottom line, you're going to pay for it and get it done if you can't do it in-house.
Great. Can you explain in more detail what a safety huddle is? It is not a term we use at our hospital.
Oh, great. I sure can. Probably about 8 years or so ago, I may be wrong on my exact timing, there seemed to be a trend in the hospitals that meet once or twice a day. Our hospital meets twice a day. It happens to be at 9:30 a.m. for the day shift meeting. All managers and directors in the whole hospital, medical director, CEO, all come together in the room for 15 minutes. And they talk and they huddle together and they talk about what are the concerns for the day. The issue may be we're slowly packed out. We got a bunch of cases that are going to need rooms in our OR, so we need to move patients out of here. We need to work on this, or we may have a concern of some type of a hospital-acquired infection going on that we need to get a handle on, or whatever the scenario may be. They talk about those, and each department gets a chance to talk about concerns and issues for the day. And as the biomed manager, I would talk about different things that are coming up. If I'm seeing a trend going on of patient monitors plugs being jerked out of the wall and causing damage to the plugs, I'm bringing them up. I'm bringing them a plug. I'm showing them and saying, hey, here's what we're seeing. We're seeing this all across the hospital. We need you to go back to your nurses and talk about this. Don't just grab the cord and jerk it out. Or you know how nurses will take tape and tape all over something to hold something on. We talk about that as an infection control issue and how you should not be using tape. Why are you not putting in a work order for biomed to call us when you have these problems? So that's what we do in the safety huddles.
Is your hospital utilizing AEM programs to assist with compliance, and how?
I do. Not the typical way that most people are with the AEM. My AEM was built around going from a 30-day grace period or 1-month grace period to a 2-month grace period. The reason I built an AEM around that is the manufacturer says this infusion pump must be done once a year. That's every 12 months. Well, if I did it at the beginning of my grace period and the next year did it at the end of my grace period, it could potentially be 14 months time frame between the PM completion. So I built an AEM around that to make sure that everybody's aware of it, everybody's okay with it. We're monitoring repairs to see if we have a larger number of repair issues during those extra 2 months for the ones that are falling into that. That's the only thing we're doing as far as an AEM.
If a manual states that the PM is required to be conducted by their company only, can we still get the PMs done by third parties who offer PMs?
Okay, this is a fun one. I'm glad you asked this question. Legally, a manufacturer can't say they're the only ones who does this. Now, nobody's going to fight them in a legal battle, okay? But NFPA 99 is adopted by the CMS. So that's a federal organization, CMS, Centers for Medicaid and Medicare Services, which is what Joint Commission also adopts that because they're doing the work for CMS and DNV. And a lot of states have adopted NFPA 99 as a state law. NFPA 99 states on there that the manufacturers must give all service manuals, all preventive maintenance documentation, access to any tools, specialty tools, for you to make the decision how to service your equipment. They are not allowed to come in and say, only we do it. Now then, does it happen? Yes. I'm dealing right now with AngioJets. The manufacturer sent me a thing for a PM. I said, no, we're doing it in-house. And they said, well, you can't. If you do it in-house, we won't work on it anymore. And I said, you can't. How do you deal with an FPA 99? This is the law. So we're going back and forth. And I'm not going to win this game. You got to deal with what you got to deal with. But third-party PM, sure, absolutely. If you got I've had this situation with an O-arm, Medtronic O-arm. Horrible situation as far as supporting biomed. They will not even sell us parts. I have found a third-party company that would service them and could service them as long as I'm monitoring and managing the compliance, that they're doing everything the manufacturer says that needs to be done. We're doing it right. We're changing batteries, doing lubrications. We're doing all that kind of stuff properly. Sure, absolutely. They can't tell you you can't use somebody else.
Do you accept tech comments such as PM completed, or do you require data such as actual measured values?
All right. In our particular facility, we do exception reporting. So if I say PM completed, just what we do, I've got to back that up with, well, what was your PM? I got to have full documentation, which can be the service manual if you're following that. Or if you've written out your own preventive maintenance procedures, you got to have detailed documentation. So if I say I passed, and anybody comes in and says, well, what is it you did to pass? Here it is. Boom. This is all the stuff I did, and it passed. Exception reporting is anything that didn't pass that. Now I do a PM with issue and detail exactly what did not pass and what we did to verify and correct it to make it pass.
How do you close a work order that has already been closed as missing?
Okay, I may be missing something on here, but let me go through it. If I've got a PM, preventive maintenance, and, I think I know where you're coming with this now. I got a preventive maintenance, and I close that as missing. Followed my process, notified the department, documented my times looking for it. I close that as missing. Now then, a corrective maintenance work order comes up on this a month or two later. Well, it shows me on my work order system that this was in a missing status. If I look at the history, I see the PM wasn't completed on it. So now then, I take that, and on that work order, I do complete calibration, preventive maintenance on it, electrical safety testing on it, document all that, found it not in use, hopefully. You found that they called you and said there's a problem with it. If you did say it was in use, you need to be talking to the manager and do incident reports that, hey, this was being used when it shouldn't have been, and deal with all of that and just close it out so that repair work order would be closed, showing that you found it, you did the preventive maintenance on it there. So your history should show, I couldn't locate it, close out my work order as an exception, and now I located it and I did my PM on it.
Great. How many PM orders per month average do the techs have?
Okay, this is going to vary by every location. I've got some hospitals that if they've got 50, they're complaining that, wow, look how much work I've got. I've got other hospitals that have 150, and it's not a problem. This is going to be varied on the quality, I shouldn't say quality, but the training that your technician has, the skill set that they have, and the type of equipment that's out there. Obviously, anesthesia machines are going to take more time to service than patient monitors and so on and so forth. I don't have an answer I can give you on that.
That makes sense. Will the PM due date be shifted as per the date of completion of CM work orders generated as a consequence of PM with issues, or will it follow the original PM period?
That's a choice. I understand that question. There is capabilities in most CMMS systems to say that I want my PMs to be adjusted based off of every time it comes in for a repair, it resets. You do a complete calibration on it. It resets the time and says, okay, it's due a year out. If it comes back in 3 months later, it resets it and does it again. There's I forget the term that's right off the top of my head here, but our CMMS has a capability to do that. We do not use that capability because we like to even out our PM completion status and time and make sure that it's equalized so everybody knows I've got my months for even. I don't want to have twice as much in 1 month than I do another month. So I don't use that. It's possible to use that. That's your call, your choice.
What software program are you using?
I'm using AIMS by Phoenix Data. We've been using it for many years. But again, this doesn't require you to have that software database, but I highly recommend it.
Excellent. The next question that I'm pulling up is as follows. We are having issues with equipment, i.e. IV pump, compression units, walking out of the hospital. The equipment is tagged with RTLS, but we do not have audible perimeter alarms. Some of this equipment has been found in the trash chute. Have you experienced anything similar, and how did you address? Obviously, this contributes to could not locate PM entries.
Yes, absolutely it does, and you need to make sure you follow the process. They call it lost as well. Have your process in place to deal with that, to get them off your books. But yeah, that's a tough one. It does happen in places more often in some places than others. If you have a CMMS, an RTLS system, they should be able to work with you on noting you when a device goes past a certain location. So if you set up your RTLS location points close to an exit door where they're going out, you should be able to set that system up to be able to send you an email or a text message or somehow notify you that this walked out the door. Now then, is that going to stop it? No. But you'll have more understanding of what is going out, when it's going out. Is it going out the ambulance bay? Is it an issue? Is it going to other hospitals? Is it going out the door? And once you get that understanding, it helps you to dig down further into it. Do you need to be dealing with the ambulance companies to talk about how you deal with this better? Or do you need to put some other kind of stop place at this particular exit because a lot of things are going out in the parking lot, this exit? Helps you to deal with that, but there's not a straightforward way.
Excellent. Well, thank you so much. In order to finish on time today, I want to conclude by saying thank you to presenter Steve Kelley, sponsor PartSource, and to our audience members. Today's webinar is being recorded, so you may re-watch for free anytime using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. 24/7 editor Carrie Forsyth-Stevens will be back in about 8 weeks. You are welcome to email her comments, questions, and future webinar suggestions. Her email address is kstevens, that is Stevens with a PH in the middle, at medqor.com. Thank you for participating in this 24/7 webinar.